Hi everyone, I'm Dr. Divya Shanthi and welcome to NEET PG Core Revision series. These series are structured, focused and exam oriented so that you can recall faster and more confidently in your exams. In today's session, we are going to break down the anatomy of diaphragm into clear, high-yielding, exam-focused concepts. So let's get started. The diaphragm is basically a muscular structure which closes the thoracic outlet. Okay, so here we see a large dome-shaped. So it is dome-shaped and muscular, which closes the thoracic outlet. It separates the thoracic cavity from the abdominal cavity. It is also called as the abdominal diaphragm, thoraco-abdominal diaphragm. So this diaphragm is the principal muscle of respiration. Okay, so it is a principal muscle of respiration. So it will have two parts. The peripheral part will be muscular and the central part will be a tendon, which we call it as the central tendon. So when we look at the origin of the diaphragm is divided into three parts. The origin is divided into three parts. We have sternal, the costal and the vertebral origin. So when we see the sternal, okay, so sternal, here the sternal part of the diaphragm consists of two fleshy slits which arises from the posterior surface of the 𝗲𝗏𝗏 process. The sternal comes from the 𝗲𝗏𝗏𝗏 process. Then we have the costal part. So costal part basically it consists of, so here by two fleshy slits and by 6 fleshy slits it comes from the costal, okay, that is inner surface of the lower 6 ribs. So near the costal cartilages, from the lower 6 ribs and the inner surface we have the costal origin. And the vertebral part arises by the means of this, you can see the right and left crus of the diaphragm. So here, so it will have basically the right crus, okay, which arises from the right crus. So this is the right crus. So the vertebral origin is in the form of this right and left crura and as well as the 5 arcuate ligaments also. So when we see the right crus, it is, here we can see it's a vertical bundle of fleshy fibers here which arises from the upper 3 lumbar vertebrae. Okay, upper 3 lumbar vertebrae and the intervening intervertebral disc and disc, okay, in between intervertebral disc. So it comes from there on the right side. Whereas the left crus here arises from the left side of the anterior aspect of upper 2 lumbar vertebrae, okay, and the intervening disc. So left crus only 2 lumbar vertebrae. Here it is 3, L1, L2, L3. Here it is only L1 and L2. Then the arcuate ligaments. When we see the arcuate ligaments here, these are basically the arched fibers which we can see. So we have the median arcuate ligament, then the medial and the lateral arcuate ligaments. So this medial arcuate ligament extends from the upper end. So you can see here this part, okay. So this part here will be the median arcuate ligament. This is the median between the upper ends of the 2 crura, the right and left. Okay, so this is the median. Then we have the medial. Medial extends from the side of the L2 vertebrae to the tip of transverse process of L1. So here median, so among the arcuate ligaments, we have the median Median will be between the upper ends of two crura. Then we have the medial, medial arcuate ligament. So basically it is the thickened upper margin of the psoas sheath. So it will be extending from the side of body of L2 vertebra to the tip of transverse process of L1 vertebra. Okay, and then we have the lateral. So it is basically the thickened upper margin of the fascia covering the quadratus lumborum. So here it extends from the tip of transverse process of L1 to 12th rib. Okay, so it will be arching like that. So it is called as the arcuate fibers. So that is about the origin. Now why do you think the right side, the right crura, so right crura, why, or the right crus, why it is attached to more number of vertebrae, whereas the left only to 2? So what can be the reason? Because the right side diaphragm has to contract, when it is contracting, it has to contract over the liver, and liver is a very huge, heavy organ, right? So because of that, it is attached to 3. Next, coming to the insertion. Insertion, what happens is, so from the circumferential origin, so it is originating from the xiphoid process, from the costal ribs, right, as well as from the vertebrae. So from all around it has the origin. So the muscle fibers, all of them, they converge towards the central tendon. So central tendon is over here. So like a trifoliate, so like a trifoliate, it's a trifoliate in shape, and we can see the insertion. So I will show you the insertion. Right. So if you see here now, we can see the costal origin. We can see the costal origin. So sternal origin was from here, the xiphoid process. So the costal origin, when we see, the costal origin was from the inner surface of the lower 6 ribs, so from the lower 6 inner surface, near the costal cartilages, we have this origin. And then the vertebral part, if you see here, from the upper 3, we have the right crura coming here, and from the upper 2, the left crura here coming. And these are this is the median arcuate, this is the medial arcuate, and this is the lateral arcuate. This is basically the psoas sheath here thickened. Then here we have the quadratus lumborum fascia, which is thickened here. So this is the arcuate. So median extends between the two crura. The medial extends from the body of the lumbar vertebrae, from the body of L2 up to the transverse process of L1. And this one from the transverse process of L1 up to the 12th rib here. So that is the arcuate ligaments. And this is the central tendon, which we are seeing where it gets inserted. So if you see here, this central tendon is like a trifoliate in shape. So it has a single triangular anterior central leaflet and 2 like a tongue-shaped posterior leaflet. So this is like the triangular here, and this is the tongue-shaped posterior leaflets. So it looks like an equilateral triangle. So the right posterior leaflet is short. This one is short and stout, whereas the left posterior is thin and long. So all the fibers, they converge over there and they get inserted to that. So it is this central tendon will be fused with the pericardium, and it is inseparable from that fibrous pericardium. Then coming to, so this is basically a closer view of the central tendon. This is triangular, the central, these are the posterior, short and stout, this is long and thin. You can see it here. So coming to the openings, okay, so openings of the diaphragm are very important. So it has major openings as well as the minor openings. So when we see the openings of the diaphragm, okay, so both major. So major, it has 3 openings and it has many small minor openings. So we will look at the major openings first. So we have the vena-cava opening. Okay, so first opening will be the vena-cava opening. Vena-cava opening. So this opening, it is located in the central tendon. Okay, central tendon here. So if you see the shape is quadrangular or like a square. It is quadrangular or like a square. Okay, and it is at the level of, that is very important, it is at the level of T8. Okay, so the opening lies at the level of T8 for the inferior vena cava to enter. Okay, pass there to the heart. So from the liver, it goes to the right atrium of the heart. So inferior vena cava. Then we have the second opening, that is the esophageal opening. So esophageal opening is more oval in shape. Okay, so it is like oval in shape, oval or elliptical. And this one, it lies slightly to the left of the median plane here. So this is at the level of T10. Okay, at the T10, level of T10 vertebrae, it is present. Then we have the aortic opening. So esophageal opening for the esophagus to enter the abdomen. And then we have the aortic opening. So this is also in the midline behind the median arcuate ligament. So now this aortic opening is more circular or round. Okay, circular. And this lies at the level of T12. Okay, so T8, T10 and T12. All the even numbers, 8, 10, 12. So at that level, we see the 3 major openings. So usually when the diaphragm contracts, okay, when the diaphragm contracts, it enlarges this caval opening to enhance the venous return. And contraction of the diaphragm will have a sphincteric effect on the esophagus. So like a pinch cock, it will just pinch it like this, okay. And contraction of the diaphragm will not have any effect on the aortic opening, okay. So for the vena cava, it will help in the venous return. Right. So coming to the minor openings, the other minor, so here we can see the vena cava opening, the esophageal opening and the abdominal aorta opening. So minor openings, which are the minor openings which we see here? So these are usually unnamed minor openings, they don't have names. So whatever structures passes through, those are the openings. So we will see the superior epigastric vessels passing. Superior epigastric vessels, musculo-phrenic artery, musculo-phrenic artery, okay, and lower 5 intercostal nerves and vessels. Then we have the subcostal nerves and vessels. Then we have the sympathetic chain, then we have the greater, lesser and least splanchnic nerves. So we have the greater, lesser and least splanchnic nerves, and then we also have the hemiazygous vein. Okay, so these are the minor openings, which are the structures which pass through small openings through the diaphragm. So there we can see the venicaval at T8, the esophageal at T10, and abdominal at T12 here. Okay, so the three openings at three different levels. So we can see aortic. So the aortic hiatus lies at the level of T12 vertebra, where the thoracic aorta will enter and continues as abdominal aorta. And at the same level, the thoracic duct from the abdominal cavity will enter the thoracic cavity. Then esophageal hiatus lies at the level of T10, okay, where the esophagus and vagus nerve will pass. And the venicaval opening, so esophagus from the thorax, it enters there through the esophageal opening where it opens into the stomach. And venicaval opening is at the T8 level. So inferior vena cava will pass through that and enters the thoracic cavity. So the nerve supply of diaphragm, okay, so coming to the nerve supply, it is supplied by the right and left phrenic nerves, okay, as well as the lower 5 intercostal and subcostal nerves. So the phrenic nerves are both motor and sensory, okay. So the phrenic nerves are both motor as well as sensory. So the right phrenic nerve will be supplying the right dome of the diaphragm, as well as the left side, left phrenic nerve will provide motor innervation to the left half of the diaphragm. And this phrenic nerve, it also provides sensory innervation to the central tendon. Okay, so sensory innervation is mainly to the central tendon of the diaphragm, along with the pleura and the peritoneum related to that. The intercostal nerves supply the peripheral part of the diaphragm. So you can see here, this is the right phrenic supplying the right side as well as to the central tendon, and here we have the left phrenic. So that is about the nerve supply. The blood supply here, okay, so superiorly, okay, the upper part we have the musculophrenic and the pericardiophrenich arteries, which are both branches of the internal thoracic artery, and the superior phrenic artery, a branch of the thoracic aorta, which will supply the diaphragm. Okay, so that is from the upper part. Inferiorly, the inferior phrenic arteries, which are the branches of the abdominal aorta, will be supplying the diaphragm. And venous drainage is through the corresponding veins, okay, which accompany these arteries. So that's how the entire diaphragm is supplied. Okay. So in addition to that, we will also see the superior epigastric arteries. Superior epigastric arteries. Then we also have the lower 5 intercostal and subcostal. Intercostal and subcostal arteries also supplying the diaphragm. So what is the action of diaphragm? Okay. So the diaphragm, it serves many functions there. One is, it is a muscle of inspiration, mainly muscle of respiration we say, right? So it's muscle of inspiration to be specific. So diaphragm is basically the principal muscle of respiration. So when it contracts, it will descend. Okay, it will descend and increase the vertical diameter of the thoracic cavity. So when we are inspiring, okay, so when it contracts, it will descend and it will increase the thoracic cavity. Then it also helps in abdominal straining. Abdominal straining, okay. So the contraction of the diaphragm along with the contraction of the abdominal muscles, right, it will raise the increase the intra-abdominal pressure. This is basically important in cases of act of micturition, defecation, vomiting, and also during parturition, that is childbirth. Then it acts as a muscle of weightlifting. Okay, so in weightlifting, this muscle has to be trained. So by taking deep breaths, okay, when we take the deep breath, and what happens, the glottis is closed there, and we can raise the intra-abdominal pressure to such an extent that what will happen is it will support the vertebrae, okay, it will support the vertebral column and prevent its flexion. So when you are lifting the weight, the vertebral column should not fall off, right? So it should stand straight. So when this muscle contracts, especially in deep inspiration, so what happens? The glottis is closed, the pressure is increased, and the vertebrae, they do not flex. So this will help the post-vertebral muscles to lift the heavy weights. It also acts as a thoracomuscular pump. So here what happens? It decreases when the diaphragm, the descent of the diaphragm will decrease the intrathoracic pressure, but at the same time, the intra-abdominal pressure will increase. So this pressure change compresses the inferior vena cava and it will help in the increased venous return. Next, it acts as a sphincter of esophagus. So these are all its functions. It acts as a sphincter for esophagus. So the fibers of the right crust of the diaphragm, it will act as a sphincter for the esophageal opening. So this is all about its actions. So applied aspects. So among the applied aspects, one is the paralysis of diaphragm. So basically the damage to the phrenic nerve. Okay, so phrenic nerve damage can lead to, usually unilateral damage can lead to diaphragmatic paralysis. So bilateral damage is very serious. Bilateral damage, it will completely paralyze the diaphragm and it can lead to respiratory failure. Then there can be sometimes we get this hiccups, right? So hiccups is basically due to involuntary spasmodic contractions of the diaphragm with the which occurs along with the closure of the glottis. So this usually occurs because of gastric irritation, that is the common cause, but pathologically also it can be because of diaphragmatic irritation or phrenic nerve irritation, then in hysteria, and when there is increased urea levels in the blood. So all this can also cause hiccups, right? Then the other things which we see are the diaphragmatic hernias. Now these diaphragmatic hernias, the congenital ones are common. So here among this we have the posterolateral hernia. This posterolateral hernia is the commonest diaphragmatic hernia. Okay. So it is basically there is herniation of the abdominal contents here, the herniation of abdominal contents into the thoracic cavity, because of which there is compression on the lung and the heart. So here the herniation usually occurs through the gap that is between the pleura and the peritoneum. Okay, so pleuroperitoneal hiatus, that is between the vertebral origin and the costal origin of the diaphragm. So this is called as the foramen of Воротилек. Okay, so here we have the foramen. So this is the posterolateral or hernia because of this gap, which we call it as the foramen of foramen of Воротилек. So this is basically this gap. Okay, so during the development this gap remains due to failure of the closure of this pleuroperitoneal canal. So usually this is common on the left side. So here we can see that. Okay, so this is the herniation which is occurred into the thoracic cavity, causing the compression here of the heart and the lung. So this we call as the posterolateral hernia. Okay, this is the most commonest of the congenital posterolateral hernia, which occurs through the foramen of 𝗏𝗏𝗃. Okay, so remember this, it is basically because of the non-closure of pleuroperitoneal canal. So this is how we will see it. Okay, so we can see the intestines within here in the thoracic cavity air filled. Okay, so we can see them like this. Okay, so this is how it is, the same thing. This is the gap. This is also called as the posterolateral hernia, also called as the 𝗏𝗏𝗃 hernia. Okay, named after the foramen. This is due to non-closure of pleuroperitoneal canal. Okay, this is during the development. It's a developmental hernia. So this is the X-ray view of the hernia. We can see here how the herniation has occurred with the collapse here of the lung. Okay, and we can see the herniated intestines, abdominal contents. Next is hiatus hernia. Now hiatus hernia, we have like it is the of all the internal hernias, this hiatus, which is also called as the sliding hernia, is common. Okay, among the commonest among the commonest of all internal hernias. Okay, internal hernias which involves all the other organs also. So it is commonest of all the internal hernias, sliding or hiatal hernia. So here in sliding hernia, the at the gastroesophageal junction, at the gastroesophageal and the cardiac end of the stomach here, right, it slides into the thoracic cavity. Okay, so only that part will herniate there. So this hiatal hernia is caused by the weakness of the, so basically it is because of the weakness of the diaphragmatic muscle, which will be surrounding the esophageal opening. So this will cause regurgitation of the acid contents of the stomach into the esophagus. Okay, so because of which there is regurgitation. Okay, there is regurgitation, and that leads to peptic esophagitis. So they will have that burning sensation. The patient complains of heartburn. So usually this condition is associated with the short esophagus. The esophagus which generally will be a little shorter. Okay, so here we can also see the herniation of the stomach. So coming to some of the image-based MCQs. So which structure passes through the marked opening? So here is at the central tendon, the opening is there. So it is the inferior vena cava. The esophageal hiatus is primarily formed by which structure? Esophageal hiatus is formed by the right crus of the diaphragm. Injury to the labelled nerve here will result in, labelled nerve is the phrenic nerve. So it results in paralysis of the diaphragm on that side. The labelled arcuate ligament here, okay, is the medial arcuate ligament. On the psoas major muscle, it is the medial arcuate ligament. The most likely diagnosis here is, it is 𝗏𝗏𝗃 hernia. Okay, 𝗏𝗏𝗃 hernia. So Morgagni hernia is basically, it is a retrosternal hernia. Okay, retrosternal hernia. So there it occurs through the gap between the muscular slips, that is from the origin of the diaphragm from the sternum, that is the xiphoid process of the sternum and the seventh costal cartilage. So there, if there is a gap between the sternal origin and the costal origin there, okay, which we call it as the space of Larry or foramen of Morgagni. So foramen of Morgagni, through that, if there is herniation, that is called as the retrosternal hernia. So that's a wrap on today's session of diaphragm. So this series will bring you one step closer to your NEET PG dreams. So stay consistent, stay focused and trust in your preparation. I'll see you in the next session.